Good afternoon, everyone. My presentation is about overview of OCT. For the postgraduates here, I'll be just running through some basics initially, and then I'll show you a quick review of the cases eventually. So what is an OCT? Is just near infrared light. The wavelength ranges from 1250 to 1350 nanometer. The tissue penetration is limited, that is 1 to 3 mm compared to IVOS, which has a better penetration. But the resolution is much higher than ultrasound and also the IVOS. So coming to the components of OCT machine, we have an OCT console, and then we have a dock, and then the OCT catheter. So this is how the console, the catheter dock looks, and this is how the catheter is connected. Now, two basic things you need to know about the OCT interpretation about the terminology is a backscatter and attenuation. So backscatter is nothing but how the light waves are reflected from the tissue and back to the catheter. So two things, one is the signal rich region and the other one is the signal poor region based on the backscatter. And then we have high attenuation. It is nothing but reduction of intensity in the light waves as they pass through the tissue based on the absorption capability of the tissue. So either you have high attenuation, which means light cannot penetrate that deep, or the low attenuation where light can pass through the tissue and then you can visualize the deeper tissue. So based on the plaque morphology, it can be a homogeneous in appearance, it can be heterogeneous. So this is how the image looks. So we have two views, that is the B mode, and then the other one is a longitudinal view. So in the longitudinal view, as the OCT pullback is done, you can visualize from the distal to the proximal part of the vessel. And the B mode is a cross-sectional view where you can see the various layers of the blood vessel. So this is how the evolution is. So we know that coronary angiography has only 200 microns resolution, and then IVOS is about 100, and then OCT has a very good high resolution of about 10 microns. So how does OCT help us in day-to-day practice? So first, this is called the MLD max. So here when we use in routine daily PCI, so first is it helps us in identifying the morphology of the lesion, and then once you decide to go ahead with the percutaneous intervention, it helps us in assessing the length of the stent, to assess the proximal and distal reference diameters of the blood vessel and the exact landing zones, and it also helps us in deciding the stent length. And once the stenting is done, post-stenting, it helps us in identifying any complications such as the edge dissection, and then if at all there's any adequate apposition of the stent or malapposition, and also in adequately expanding the stent. So here coming to the structural morphology, there are mainly three types of plaque, that is the calcific plaque, fibrous plaque, and the lipid pool. Apart from that, it also helps us in identifying the thrombus burden by saying it's a red or a white thrombus which is more organized, helps us in identifying thin cap fibroatheroma which are more vulnerable for plaque ruptures, helps us to differentiate between a rupture and erosion, and also can identify cholesterol crystals and just plain intimal thickening. So these are the major, so this is a normal tissue, that is we have the intimal layer, and then a little lucent layer is the media, and then the outside layer is the adventitia. This is a normal coronary anatomy. And we have a calcific plaque where the margins will be very clearly delineated. It is heterogeneous appearance and has a low backscatter. Coming to fibrous tissue, it has a homogeneous appearance with high backscatter and low attenuation. And then we have the lipid pool, which is also homogeneous, but then it has low backscatter with high attenuation, so it appears really bright at the margins. And then you can also differentiate between red and white thrombus. So here red thrombus is more acute, it absorbs light and so has high backscatter, does not allow the beyond the tissue visualization. Coming to white thrombus, it's a more chronic thrombus, homogeneous, and has high backscatter. Also, this is how you can actually visualize the stents post-stenting. So in the right side image, you can see that the struts are not adequately apposed. This is how we can optimize better by using OCT. This is an image of an endothelized stent. There's a nice neo-intimal coverage over the stent struts in this. So this is just a summary of the basic plaque morphologies based on the backscatter and the penetration. So this is how a longitudinal view is just a summary of the thing. It helps us in identifying the dissection, if there's any tissue prolapse, malapposition, helps us in differentiating and identifying the diameters and then deciding the stent length. Also, this is just a bifurcation. This is a fly mode in which helps us in bifurcation PCI. OCT, despite how IVOS cannot, we can also identify the involvement of side branch ostium and then decide if we need to cover it or if the diameters are adequate. Now coming to the cases, this is a case of a 70-year-old gentleman, no comorbidities, presented with stable angina, treadmill was positive, its echo is normal LV function. So here we have the coronary angiogram. is basically there's some angiographically it looks around 50% involvement of distal left main, and the ostial LAD looks nearly 70%. The circ ostium looks relatively clean. The syntax score 1 in this patient is 9, and the RCI is quite normal. So here we did an OCT pullback in this patient to assess the diameters. The OCT was done post ballooning. So the first picture is the ostial LAD, which has a diameter of area of around 3.8 mm square. So here basically I'm showing you these OCT images to actually identify the minimal lumen area and then to decide the stent size and the stent length. That's how OCT helps here. So we went ahead with 3 mm balloon dilatation, and then the stent was deployed. So this is the post-stenting angio. After the stenting, you can see that the ostium of the circumflex is slightly pinched, and also there's some hazy appearance, looks like a dissection at the ostial circ. So OCT helps us in identifying what exactly is happening with the ostium of the circ, and it helps us to further proceed with the next step. So we went ahead with the bifurcation technique, that is the tap technique. So we placed another stent across the ostial circ, and then kissing balloon inflation was done, and this is the final result. And final OCT was done, which showed adequate diameters, very nicely expanded stent in the LAD and the circ. Now coming to the second case, this is a 73-year-old male who is a long-standing diabetic and hypertensive, presented with effort dyspnea. LV is normal in function, positive treadmill. He underwent a coronary angiogram elsewhere. So there's involvement of left main, and here you also can see that there's a significant involvement of the OM. Osteoproximal LAD is about 50%. The syntax score is around 26. Both the options of CABG and PCI were given, and then the syntax score is, the mortality is equivalent for both the options. So we went ahead with the PCI, but then here in view of the low ejection fraction, we used an intra-aortic balloon pump. We ballooned all 3 blood vessels, and then we did an OCT pullback. The OCT actually showed there's a 270 degrees arc of calcium in the LAD and nearly 360 degrees arc of calcium in the circumflex. So we went ahead with intravascular lithotripsy, post-ballooning. You can see in the lower image that OCT is clearly showing us the disruption of the calcium from the cracks there. And then we went ahead with the bifurcation stenting technique. DK crush was done, and then, so this is again the bifurcation view, which is just showing us that the ostium is free of stents post-kissing. There was some malapposition, which is optimized with a report again, and this is the final result. So apart from the regular elective PCI in patients with stable ischemic heart disease, now, just give me a minute. So now we can actually use OCT for contemporary management of ACS in young patients. I just have 2 case examples. This is a 38-year-old male presenting with inferior MI. EF is about 50%. He underwent angiogram elsewhere, which was 100% occluded mid-RCA. So he presented to our center, and after wiring, this is what we have seen, that the mid-RCA and beyond is completely high thrombus burden. I know routine thrombus aspiration is not recommended, but here there's a very high thrombus burden and it looks like an ectatic RCA. So we used a Hunter's aspiration catheter, aspirated some amount of thrombus, and then this is what is after aspiration. You can see in the panel that there is some residual thrombus. So in this case, we just went ahead and used intracoronary thrombolysis, and 48 hours pre-discharge, we just did a check angiogram. After the thrombolysis, the flow in the RCA looks better, and the OCT just showed us red thrombus. There's no plaque erosion, rupture. It's just a thrombus-filled RCA. So we just discharged him with triple therapy, which included NOAC. And then after 4 weeks, we did a check angiogram, which looks TIMI-3 flow, and there's no visible thrombus angiographically. That's how imaging helps us. And then this is just last case about a 21-year-old male who presented with anterwall MI. He's a football player. Apart from premature history of CAD, there's no other significant history. And this is the presentation ECG, which had RBBB with ST elevation. So this is the initial angiogrammic picture, which showed 100% occluded proximal LAD. We just did a thrombus aspiration in this patient also, which is showing mild mid-LAD disease. And then the OCT here showed some red thrombus, but then the luminal area was not so bad. It's around 4 mm square. So we decided to leave him with medical management. We also discharged him with triple therapy. This is the initial ECG presentation showing the red thrombus. And then after 4 weeks, we did a check angio. The ST settled. And then this is the post-OCT at 4 weeks follow-up. There's only a fibrolipidic plaque in the middle LAD with around 40% stenosis, and the lumen area was good. So this patient, there was no need to stent him because the underlying morphology, the lesion was just a plaque erosion. And after 4 weeks, it was good. So we just kept him on dual antiplatelet therapy. Last but not the least, the usage of OCT in instant restenosis. It helps us in identifying the reason for instant restenosis. That is, if it is a neoantimal hyperplasia, neoatherosclerosis, or is it due to malapposition, underexpansion. Based on that, we can just go ahead and treat with drug-coated balloons, avoiding repeated stents. So this is just the summary how the OCT helps. Thank you.